Uh, so my name is Rodrigo. I'm an associate professor here in this university. I coordinate the link. The link is a clinical neuroscience lab that congregates very different modalities in neuroscience. And I'm part of the schizophrenia program here. And we set up some other programs that I'll make clear during my presentation. So the title of my presentation is more focused on at-risk mental states. And I'll try to bridge the gap from our initiative on at-risk mental states with this Y-Mind initiative. So those are my conflicts of interest, quite a few. I'm very complicated, and if I would list, deeply, it would be much more. But 95% of our grants actually do not come from the industry. So taking mental disorders in perspective, I think we've heard many talks today, and we have this in our minds now, that even for PTSD, that you need an event to diagnose that. We all think about risk and the development of the disorder itself. I am a schizophrenia guy. I've been studying schizophrenia for quite a while, and schizophrenia is one of the fields that kind of pulled this perspective. So we think about premorbid, then we think that some people might be at risk, and then we think about ultra high risk, and I'll talk a little bit about that. Then you get your first episode, and then you have your career. Some people will not migrate to mental disorder, but a few will, and then you go to chronicity and/or treatment resistance. And you can think about that in terms of stages. It has been, implemented in the clinical perspective, and it has helped people. Mainly, if the interventions here are not quite the same as here and here, and it does help. But if you want to understand and to avoid the migration from one step to the other, you have to understand a little bit better what's going on. Let me see if I. Okay, so quite a few slides are still in Portuguese. I must say that I'm almost lazy because my computer was stolen, and I still have some slides in English, and my English slides weren't here. But this concept is widely talked about. What is ultra high risk for psychosis? Is somebody that has some symptoms that are not enough or strong enough to fulfill the criteria for psychosis. You can have brief psychotic episodes, like an hour, less than a day, or you have some attenuated symptoms, like I heard a voice. I'm not sure if it's from my mind or not. It repeated, it came another day. I'm a little bit, I think this teacher is a little bit strange. My mother is giving me some strange foods. Don't know exactly why. What do you think? Do you think, somebody's against? No. This is coming from my mind. So these kind of people have been identified from the Australian group in the beginning, when they're studying first episode psychosis. And they said, there are some guys here that do not fulfill criteria, but they're a little bit strange. We should follow them up. And that's how they selected this criteria. They actually included not only attenuated symptoms or brief symptoms, but also having a close relationship with somebody with the disorder and decreasing your functionality. That's interesting, isn't it? It's a criteria, how people come up with that. Because they try to follow them up, and quite a few converted. Okay, you've seen 41% in the very first studies. 41% in 1 or 2 years. It is an ability of predicting such a major disease with a very high rate. But there's a problem there. Even if it's 41%, if you're identifying 100 people, 41 are going to have the disorder. How about the other 60%? Do they have the disorder? No, they don't. They don't develop the disorder. Are we overdiagnosing? People love this story, isn't it? They love. Do they have problems, the other 60%? Yeah, they do have problems. They are help-seeking people. But, in terms of thinking about schizophrenia, this is very important. That was a huge step in terms of understanding the disorders, because we're moving from where we start as doctors to somewhere else and to study it deeply. these transition rates, they've been changing. And what's the main reason, we think, is recruitment. The less severe you recruit, the lower the chance of people converting. But you know, I'll just, you know, go through this perspective. I won't go in very much detail. But there are some things that are important. People are studying those guys deeply. And what happens with the brain? What happens with the brain of those that before conversion that are at risk and compare with those that were not at risk? They already have some reductions in terms of cortical thickness. Imagers guy, they love that because, you know, you're improving your accuracy now, and you can, you know, show group differences with very high precision, let's say. And what happens is that those that convert do reduce more, you know, lose more cortical thickness than the other ones. So something is going on. It wasn't only a clinical thing. Something is going on in the brain. And there are several studies showing that. I'll let you know. The other study that is very cool, and I'm a dopamine guy in schizophrenia, is that they measured how was the dopamine production in the cells. That is very well established that people with psychosis do produce more dopamine in the presynaptic cells, the dopamine neurons themselves. And if you compare two controls, you generally find a difference. This is well replicated with an effect size of 1.8, 2 point something. What happens is that if you pick those guys at risk, you will get an intermediate amount of dopamine release. Very interesting. So is the disorder already going on here? No, this is not a diagnostic marker, and there are quite a few people releasing dopamine similar to the average here. But it shows a concept. The concept is there. Something is going on. Before the disorder, those guys are already releasing more dopamine or producing more dopamine. I won't go through all the papers of this group, this Phil Maguire's group and Ollie Howe's productions, but many of those that will convert in the future were those that were producing more dopamine already. Next one. And what's going on? Dopamine doesn't explain the whole disorder. We all know that. You saw there that quite a few people, you know, release dopamine similarly to the other guys. And there is a very good hypothesis that glutamate might be influencing that. And that's what they've shown. There is an abnormal level of glutamate measured by spectroscopy MRI. Next. And what is interesting about that is that reduced hippocampal glutamate predicts elevated striatal dopamine. That's exactly how people think about the hypothesis. Actually, it's not only that dopamine is dysregulated, but it's one of the hypotheses that the neurons that are regulating the dopamine neurons that actually are strange. And what's going on? We're getting here a very nice correlation. People always say, no, this Phil Maguire's group, they are always making those things make so easy to understand. It's only one study. Nobody replicated. Why? Because it's very difficult to replicate. It's very difficult to get those samples. But anyway, we are going in the same direction. It makes sense. Next. And, you know, if there is a problem there, can we treat? Should we say treat? Or can we prevent those things? What are the strategies that people think about? Let's give antipsychotics to those guys. They are a little bit weird already. Let's give CBT. That's what we think. Of course, we're doctors. We only know that. So people try that, and there is an effect. If you see, those are the differences in rates of conversion. People with CBT plus risperidone compared to placebo and sham. Here is only CBT, the differences here, olanzapine here, and there are side effects. We're talking about drugs. We always have side effects with drugs. Olanzapine in specific for young guys, problem. But there is one paper that kind of shaken the field. What happened? This guy gave, this is an Austrian guy, Eminger, he gave omega-3 to those guys. Omega-3 works for psychosis, depression, bipolar, several trials, beautiful trials, only associating, nobody's crazy enough to give omega-3, and some are positive, but the magnitude of the effect is very small. Here, we see a different thing. We decrease the conversion from 27 to 4.9. We're giving vitamin. What's going on? How come? How come it works now and doesn't work before? The idea is very simple. It's just the same idea as heart attack. Are you going to give anti-cholesterol drugs to somebody with a heart attack? You can give those drugs to prevent a next heart attack. But generally what we have is we are putting stents in these people. So the treatment for early phases for prevention, it should be different. Well, this trial is being replicated now. It's only one trial. It's beautiful. The data is very good. But it's been replicated in multi-centers. Bruce was talking about, the NIH is also involved. But this was so big that, next please, that made people from the DSM-5 think that we should have a diagnosis for those guys. And they used this name, attenuated psychotic symptoms syndrome. If you ask the people that really carved the idea of ultra-high-risk psychosis, do they like a diagnosis? Isn't it nice? We think about something, it's in the DSM-5, they hate it. They don't like this idea because they don't think it's valid yet. But why, I've been to several discussions about that. Why, at the end of the day, people are trying to include a specific Tom McGlashan defense, the inclusion. It's not in the main diagnosis. It's going to be one of research appendix. Because if there is a treatment such as omega-3, how the US is going to deal, or the world is going to deal with this thing? You have to fit in something. So the impact of something working in this thing is already impacting our classifications. It's not there yet, but it's a sign. Next. Okay. And what happens is, as I told you, and that's a slide that we produce, what happens is that there is neuroadaptation. There is a process there. Macroscopic cortical thickness is something that shows that. Of course it does, but neuropsychology shows, functioning shows, a lot of things shows that the brain is not working the same way as it was. And how can we avoid, and what are the perspectives? Again, next. Next. So the idea that we started thinking about was prevention. Nowadays, the NIH do not like this perspective of primordial prevention, primary, secondary, or tertiary. Primary would be picking somebody with high risk and preventing from having the disorder. But then you can change the environment and reduce risk in general. So you reduce, you put iodine in the salt, and you reduce thyroid problems in the future. So those kind of things. But we like this idea because this is already secondary and tertiary is already treatment. It's true, it's treatment. But we are always preventing the next episode when I think about schizophrenia. So we took this perspective of prevention and started setting up, next, this why mind. So that's where I go to the why mind. So what was the idea of why mind? We had a grant on schizophrenia and all the steps that I've just shown you. Big grant, bipolar and schizophrenia. Happy to do that with ultra high risk first episodes, comparing a lot of things, imaging, genetics, all the things. But then we had this opportunity. And why we had that? Because this agency that was here in the very, very first day has this beautiful grant. It's 4 million reais a year, $2 million more or less a year, for 5 years up to 11. That's a beautiful grant, isn't it? Who wouldn't like to do that? But it's a huge grant. You have to congregate a lot of people, and you have to say that you're going to change the world. They're not going to give you money if you don't. So we started thinking about this grant. And how can we change the world? Previous one. Let's put together everybody that does good stuff, and that Jair has good relationships. And Jair, when you invite people to get in the grant, and you ask them, do you want to play? And Jair is coordinating and so on. He said, yes. What are you going to do? It's the next question is, what are you going to do? So we thought about developing cutting-edge studies in to prevent mental disorders. And to tackle, this grant is focused on high complex problems. And mental disorders, we can say easily that it's very complex. So what was the strategy we took? Next. We focused on 4 items. There are several. has been very widely studied, and Thomas Inzel is somebody that sets policy, and we use a lot of his ideas. It's not only his ideas, but we focused on limited biological knowledge. How can you prevent heart disorder? You need to understand how the cholesterol, deposits in the arteries and so on. Poor effectiveness of available treatments. There is quite a bit of gaps in the translation of current knowledge to clinical care. That's what Christiane was talking about. We have some resources, but we can't implement. She was showing that you can implement even in poor places. And we have a big thing that is stigma. Stigma is much bigger than we think. If you take in a perspective, or in a public health perspective, the fact that you don't understand this problem and you get prejudice, it's a big impact. So we divided in 4, and we thought about setting up units to tackle one of each. And how the units worked. We took all the resources where we already had. So if you think, we thought about setting up a center for mental health cohort management. Why? Because we have several cohorts. And we have to do it professionally. And what's the problem of Brazilian research? FAPESP does give us quite a bit of money, but it doesn't give money to hire people, only for scholarships. It's very hard to run serious science here in Brazil in this sense. So we have the opportunities, but it's tough. So the idea would be to get, and this grant is a little bit different. You can hire people. That's the only FAPESP grant that you could. And we wanted to set up a strategy for all the cohorts. Which cohorts? You probably remember, Guilherme Polanczyk presented that. The 6 to 12 cohort, the birth cohort. We have this first episode and treatment-resistant cohort ourselves here. So it was a strategy to put everybody together, or quite a few groups here together, to work on those things. And with the perspective of integrative neuroscience approach. Next. So the idea is that we pick each of the steps and we do as much as we can. So we investigate the sleep, we investigate DNA, RNA, and all the other things, and try to push forward and understand a little bit better. Could we do more? We could, but this is quite a bit already, because all these people that are running those things are well-trained and established researchers in these fields. Next. So the idea here, it's not only play with neurobiology, and then there will be the animal models. I won't get in too much, because Vanessa Abilio is presenting a little bit of the animal models approach, and it's the animal models approach is completely linked with the trials approach. And actually, we also decided to go to the community. So this grant is, since it is so big and congregates so many people, we were very ambitious in this sense. Next. I need somebody to tell me about the time. Is anybody? Okay, I'll go. So this is one of, just to give you an example how this kind of management of cohorts would work, and I'll show a little bit of science, just to give you a perspective. So this is what Guilherme presented. We started from about 10,000 kids, selected 2,500 and did all these evaluations, and then brought to the MRI in São Paulo and Porto Alegre 750 and blood and so on, with full neuropsychology and so. One of the areas we study and we collaborate with Jim Van Oz that was here is studying psychotic symptoms in the general population. And Thais Moriyama has adapted the CAPE. CAPE is the scale developed by Jim Van Oz to children, and adapted, the language adaptation as well. So by understanding, in 2,500 kids how those symptoms distribute and what happens with those symptoms, and in a longitudinal perspective, we will have a lot of data. So just to give you an idea, this is a comparison between CAPE, that is this general population psychotic symptoms, with the ultra-high risk symptoms. So you get quite a few good correlations between between the unusual thought contained, perceptual experience, and speech organization, and not that much with blunted affect. So it doesn't seem that those kids are already with blunted affect. Next. And those symptoms, these CAPE scores, when they are higher, they are very correlated with difficulties expressed in SGQ. So I'm not going to go into very much detail here, but the idea is that the symptoms are already there, they are spread, and they have an impact. There is a correlation with school fail, dropout, and lower positive behaviors, being friendly, being hopeful, and so on. Next. And it is associated to traumatic life events, which is predictable. My question is, do you think those guys are going to be psychotic? I don't think so. Very few will. 2,500. It's not that many. But what is interesting is that psychotic symptoms are already there and are a marker of general psychopathology. And what we've been seeing in other studies from Mary Cannon as well is that it can predict some other symptoms and perhaps even suicide. There's a new paper from her. So there is quite a bit to be studied here. Next. And correlated with deficits in some aspects of cognition. Next. And what we're doing as well, this is not psychosis anymore, we're going back to normal. So we are doing trajectories of brain development. We have 6, 7, 8, 9, 10, 12, 13. So we can do those trajectories by measuring that. So we are measuring those trajectories, so how the frontal lobe develops all over the years. And then we can compare the trajectories of those that might develop the disorder themselves. Next. And we are also doing with John Sato, that is here in the audience, some evaluations of the function connectivity of the brain. What's going on? How are the brain regions connected? And we can do that in terms of different ages. Next. So we can measure along the ages what is the strength of the connection between the right posterior cingulate to the medial superior frontal cortex. This is the control network. How does the control network is moving all over the time? So this is the very beginning, only the healthy children. So, but we will be able to do that in terms of those that will develop other disorders and so on. Next. The other thing we decided to do was to do a Center for Clinical Translational Clinical Trials. And remember that guy that is a big friend of Paris Hilton that presented yesterday, you know, the red tie? So that guy is, you know, he's mad. He's always talking jokes. I always think that this guy only does science to come and say those kind of jokes. But they are very creative over there. So they use cannabidiol, and we're going to show a little bit about that. But here, the same group used sodium nitroprusside to change a little bit the field. And it's very impressive data. I'm going to show you next. So what's the idea? I don't know if you know this receptor. NMDA receptors are glutamate receptors. Danny Weinberger says that this is the holy grail of psychopharmacology. When he was seeing my PhD thesis, he told me, this is the holy grail. I said, what? Why? Because it modulates neuroplasticity. It's through here that we decide which pathways should we enhance or not. And what's the idea in psychosis? If you give PCP, ketamine, or some drug that blocks NMDA receptors, you decrease the level of calcium inside the cell, and you produce you produce less nitric oxide. Interesting, cool. Everybody knows that, and you get psychotic when you get that. What those guys thought next. So that's the guy, but there is a troop. And this Turkish guy, Surdur, is one of the brains there. So the idea is NMDA blockade, reduction of the enzyme, lower levels of nitric oxide, PCP psychosis. Next. So these guys noticed that there is a lack of this PCP-induced effect in mice when they have reduced nitric oxide synthetase. Next. And the blockade of phencyclidine-induced effects by a nitric oxide donor. What's that? Nitric oxide donor. You can infuse sodium nitroprusside in a person or in a rat, and you give sodium nitroprusside for all the cells. And what happened? And João Paulo gave me some slides, but it's not working. It's beautiful because you see the rats, with ketamine or without ketamine. When you give a nitric oxide donor, the rats do not become psychotic. But I told you these guys are crazy. And they decided to do it in people. It's simple because sodium nitroprusside is a drug that you use for hypertension. And you can do it in all emergency clinics here. And they decided to infuse for 4 hours. So they recruited 36, 12 in each group, 2 withdraw, 10 followed the study. Next. That's what happened. Those with placebo here those with sodium nitroprusside. So this is 1 hour, 2 hours, 4 hours. Already in 2 to 3 hours, you had a huge decrease in BPRS. Same thing with PANSS total. PANSS is a scale of general scale for positive, negative, symptoms and general psychopathology. Everything decreases. How come? What's going on? Is it an effect of lowering the blood pressure? It's not, because the dose they were using doesn't decrease that much the blood pressure. It's impressive. And what is more impressive is that this effect lasted for up to 4 weeks. We've been doing those, and did it last longer? They don't know because they didn't follow. We are doing some patients already, treatment refractory schizophrenia, and it's lasting for 3 months. Very interesting, but we're talking about treatment refractory schizophrenia. Those that are refractory to clozapine, tough guys. The disorder is very well progressed. So what's the idea of this kind of clinical trials unit? The idea is that we're moving this approach to drug-naive patients. Why? Because the disorder is not well established. Can we move to those guys with ultra-high risk? We could, but it's tough. We're not going to do it now. So the next step with this research is that by modulating this thing, it is possible that we can avoid the progression because we are targeting neuroplastic sites. We're not targeting the end effect that is the increase of dopamine. Next. So the other thing that this is very much Jair's perspective is that we have to change the community. We need an epidemiological approach. And then, if we had money, we dreamt. And we thought about using some, with the collaborating units. This is Euripides, the first guy from USP that was here. The 2 of them were coordinating, so there was a site in USP here, and a site here in São Paulo, and another site in center São Paulo that, the crazy guys work there. So we would start some units, community units, all focused on prevention. First episodes and more than that in ultra-high risk. Ultra-high risk for what? Psychosis? Yes. Bipolar? Yeah, why not? Why shouldn't we start doing that? Crack cocaine? Why not? Huge problem here in Brazil. Why can't we think about ultra-high risk for crack cocaine? We started, put a team of addictions guys to study that. Not very well established. Hard to create a criteria? No. My brother smokes crack cocaine. I smoke cannabis. I'm doing poorly in school. I started, robbing with him. Am I going to start crack cocaine? Oh, there's a very high risk you're going. And if you want to change or change trajectory, you've got to be there. So the idea was developed here. Of course, this is well inspired in Pat McGorry's, Helen's work. And the idea was to bring it and adapt to our culture. We have here in Brazil, it's an interesting thing. Cristiane mentioned Bolsa Familia, mentioned some other strategies that we have here. But there is the CEL. What is the acronym? What the CEL states? It's a center for community center for leisure and so on. That's the kind of place that, talking to some politicians, they would love to have that. It's a little bit far away from mental disorder, more in health. Next. And also, we did want to focus on stigma as well. We had to do so. You have to modify that. And there are several ways of doing that, and one of the ways that we collaborate with Stan Kutcher that presented here in this conference before is to go to schools to decrease, knowledge improves, decreases stigma. The more you know, the less you prejudice. Is it the only way? No, there are several ways, but I'm gonna go through one of our strategies. So next. So that's the project. Keep clicking. Yeah, so the idea is to promote mental health. The objective is to, decrease stigma. Next. Somebody can help you, a friend, family, professor, even a professional, health professional. Ask for help. We mapped, you can keep clicking, we mapped what were the thoughts about mental health in schools, and it's a lot of prejudice in there. Keep going. Keep going. This is a network of meaning. Yeah, keep going. Sorry about that. And the next one. And we mapped where the information came from. Crap. Only TV. It's horrible. Our government is not giving information at all. So we decided to start doing a site. It's called Mind's Health. I think it's the best translation. And to give good quality information to the general population. And then we decided to create this Why Mind. Isn't it cool? I think the best product of this conference is this thing. Did you get it? Jair is selling it for $50. Yeah, we have to make money to finish the thing. It's beautiful. The idea was great. Hard work from the whole team. But there was a side effect of this thing. We didn't get the grant. But in the process, when you start thinking about those crazy grants, you get excited. You think you're going to change the world. We decided to apply for the São Paulo School of Advanced Science. So a few people are asking, why did you have so much money? Actually, we don't have the money. We are putting some of our money to organize this conference. But FAPESP, that is this very interesting research foundation, gives us, this amount of money to bring and to internationalize our groups, to cross-fertilize and whatever you want to say. So that was the side effect, was this conference. Magnificent side effect. People were cross with me that I was going to call it side effect. So the idea is, since we have this view, why shouldn't we kind of push hard towards prevention? In the beginning, when we were writing those things, prevention of mental disorder, can you do that? And we started thinking about it. Tough, nobody's thinking that it's going to prevent everything. But if we don't shift our minds, that's the thing. Is this ultra high risk very stable or not? I don't know. But I want to study that because this might change the way things go. Next. So why are we here? Why bother? Why mind? Next. And why bother about youth mind? So that's the focus. So the whole logo came out of it. Next. Because we mind. I think all of us mind. So we all mind about why mind. Do you like it? That was good. Next. I called for, Next. So this is the group, the clinical group, and we have the ultra high risk clinic, the Cuca Legal, and the child psychosis group as well. Next. This is the INPD, the big grant with Veri, leading, and Brody, Guilherme, everybody there, Andrea, Jair, everybody. Next. The link, the team with the white coat. Nobody wears a white coat, only in the photos and when they touch the rats. Next. And now we have this thing. It's the whole group. The picture is quite okay. So the idea is to involve all of you, in this initiative and try to exchange and touch you by this idea. Thank you.